I would like to introduce Professor Javier Neyra from University of Alabama in Birmingham, and he will talk about CRT Net Initiative lessons learned and applied.
Thank you very much for the invitation, and to Ravi, this was a great meeting. Really enjoyed a lot. So I'm going to talk about CRRT Net. And first, this is a registry project, and I'm going to discuss a little bit of the study design, and then the first report, that is the epidemiology of this data. So this is a prospective multi-center observational registry of adult patients undergoing CRRT. It involves 6 study sites in the US and Canada, and initially was designed to target approximately 2,000 patients being recruited. Patients receiving CRRT for less than 24 hours were not considered in this registry. Data collection included a lot of information, including characteristics and baseline at the time of baseline ICU admission and also the time of CRRT initiation. Details on the CRRT prescription and the delivery of CRRT, including machine-generated treatment data, which is very novel, and also patient outcomes. This is the study team. As you can recognize some familiar faces here. The sites that participated were University of Alberta, with Sean and Oleska there, the London Healthcare Science Center with Andrew House, University of Michigan, Michael Hearn, University of Mississippi, Luis Juncos, and also University of Kentucky, where I was before. Of course, this was led by a pediatrician. You heard a lot of the surveys before, a lot of them in pediatrics. Stu Goldstein spearhead and lead this project. And we had really a great project manager that was Robin Piazza, that organized all the data structure and also provided excellent support for the collection of this data with the coordinators. So the design of the study was published a few years ago, as you can see there, included a lot of information, including these case report forms. This is just for you to have an idea. This was a registry that was collected manually by research coordinators. So there was a lot of training for them, and the team needed to focus on people that have understanding on CRRT. And most of the time we recruited ICU nurses to collect this data. So there were many case report forms. Some of them were like intake patient forms that collected in this fashion all this information electronically. We have a CRRT encounter CRF. We also have ICU data CRF. Interestingly, the ICU data CRF, as you know, the data in the ICU is dynamic. We couldn't collect manually all the data that comes every day in the ICU flow, but this was designed to be collected twice a day in the first 7 days of the ICU stay, and then once a day from day 8 to day 14, the ICU data. And this included, of course, parameters that you can use to calculate the SOFA scores, hemodynamic data, medications, etc. Laboratory data, similar fashion, was collected twice a day in the first 7 days, and then once a day in the subsequent 7 days. CRRT data with a similar time interval, right, which was a combination of feasibility and also recognizing the importance of the dynamic data points. And of course, carefully validated outcome data. Why this is important? Because a lot of time when we interrogate data from EHR or big data, we need to adjudicate outcomes. Of course, mortality is a very hard outcome, most of the time accurate, but kidney recovery becomes challenging sometimes to adjudicate when we evaluate big retrospective data. And here we have humans that are evaluating with all the reviewing the discharge summaries, the notes, and also interacting with the team that treated the patient about kidney recovery. This is a summary, busy, but just to have an idea, if you organize all these data points, we have demographics, comorbidity data, ICU admission date, data, CRRT data of the characteristics of the patient at CRRT initiation, characteristics of the treatment, and also a lot of machine and outcome data. So why this is important, and I think Akash brought this point very nicely, there is a lot of heterogeneity in practice. And this is important. Data can generate the ultimate goal, that is precision medicine in CRRT delivery. And generating these data resources, the survey data, registry data, is a first step really towards this goal of precision medicine in CRRT. Now, I'm going to report in the last few minutes the first study we did that is evaluating the data for describing the epidemiology of CRRTnet. So this is the first report that was published a few months ago in Kidney Medicine. As you can see, we were able to interrogate with validated data at 1,106 critically ill adults with AKI requiring CRRT, more than 24 hours. So the initial survey has approximately, we closed it, but this registry has close to 1,600 patients. In the first interrogation, we still have a lot of data validation processes and incomplete data that was in the process, but we wanted to report because we thought this is at least 75% of the data, a good report on epidemiology to start pushing forward the reports. So here, as we also noted, that despite initially the survey was intended to include only AKI patients, that we identified there were some ESRD patients that were included. We took that as an opportunity because there's a subset of patients that exposed to CRRT you can examine later, but in this report are excluded particularly. And importantly, as you can see there, the mortality rate in this population was 58.9%. And this is a very diverse focus on North America, but important diversity of populations represented here. What are the sites in terms of not only of the lead people in the sites, but how these sites operate? We collected this table that you can see the site have an average of approximately 15 devices of CRRT, so fluctuated from 4 in some hospitals up to 20. The total of number of ICU beds fluctuated from 40 beds to 180 beds. We importantly determine who is the physician in charge of the CRRT prescription. In most of the sites were nephrologists. There was one site that was intensivist. And also who monitor the prescription, who decide on discontinuation of CRRT. This is North America, so most of these deliverables of CRRT are by nephrologists, although in some sites in Canada, intensivists were also heavily involved. And importantly, these are sites that have established protocols. They have dedicated education for CRRT, so may not be a representation of sites that are smaller in volume, but also don't have capacity to educate and create response teams and CRRT education teams. So some of the data, as you can see, this is classified based on survival. Not surprisingly, demographics. Patients that did not survive, that were in the ICU and required CRRT, were older. A lot of them, most of them were men. BMI was not different across the two groups. And naturally, people that died in the ICU, they had higher Charles Sloan scores, more comorbidity overall than patients that survived. When you look into ICU characteristics, you can see, not surprisingly, on the top of the table, Apache scores and SOFA scores were higher in patients that died in the hospital or ICU. But the interesting thing about this registry, you start to see some reporting on data that is not commonly seen in ICU CRRT studies, like the primary admission diagnosis that was well validated because this was collected manually. And you can see the diversity of diagnosis for admission to the ICU that fluctuate from sepsis, AKI, and a lot of cardiovascular complications. The very important thing, and this is not very common in tables that you will see in observational papers, the two important parameters, contributing factors to AKI. A lot of times when we look into AKI data, we always recognize the challenges of identifying the etiology, the potential contributing factors. So here we classify contributing factors into related to sepsis, cardiogenic, hepatorenal, major surgeries, and others. And also, this is very unlikely to be seen in other studies, CRRT indications, right? What were the indications driving the decision of CRRT? At the same time, we collected characteristics not only at ICU admission, but at CRRT initiation. You can start seeing some differences between the SOFA scores in non-survivors were higher not only at ICU admission, but at CRRT initiation. And we have different data, including one parameter that we look very carefully, that is fluid overload from ICU admission to CRRT initiation. You can see, interestingly, in this study, sites were very proactive. So the mean fluid overload at the time of CRRT initiation was 5% only. And there was no difference in the survivors, non-survivors. Perhaps because these sites were very skilled in recognizing fluid overload and not waiting until 10-20% to initiate CRRT. And this is very interesting as well. We were able to compare by sites the heterogeneity that was alluded before, and you can see here how we have granular data on the catheter position, the type of catheter. You heard yesterday a very nice lecture about the potential utility of tunnel lines in patients with in acute settings like CRRT. We have that data, the prescription in terms of total effluent dose, and also the modality, as I was mentioned, in Europe was CVVHD most frequently done. In the US is CVVHDF, or in this US-Canada registry, CVVHDF was most commonly done. Anticoagulation, in these sites, most of the anticoagulation used was citrate, as you can see there. Some characteristics that are very relevant, not only to highlight the heterogeneity, but also to identify some practice variations and some outcomes related to these practice variations in the future. This is a visual representation of some characteristics that we typically pay attention to for CRRT delivery. Where is the catheter position? On the right side in red, you can see the mortality rate according to that characteristics. And on the left side in blue, you can see the frequency of these characteristics in this population that we study. As you can imagine, most of the catheters were temporary lines, very little use of tunnel lines, but there were some. And interestingly and positively, most of the site most commonly used for CRRT was the right IJ. In terms of those, you can see the distribution. As I mentioned before, CVVHDF was the most common modality, and citrate was heavily used in these sites. In terms of study outcomes, you can see the ICU mortality was 55.4%. This is important because it can serve as a reference for at least North American sites of this volume of patients, that this is a metric to target, about 55% of mortality rate. There were still some patients that died after ICU, still in the same hospitalization, 3.5%, as you can see. Very important thing to recognize here is when we look into survivors of CRRT, and it was mentioned very elegantly earlier, especially AKI CRRT, ICU survivors, they are very debilitated. And for example, here, half of them were still HD dependent at the time of ICU discharge. This is important because it highlights the importance of communication between the intensivists and the nephrologists to transition a patient still requiring dialysis after ICU discharge. Need of tracheostomy, 24% of these patients needed tracheostomy, and these are survivors only. And importantly as well, 1 out of 3 patients were still dialysis dependent at the time of discharge from the hospital. Now, despite this data and other data sets can serve for risk classification, and hopefully in the future we have better tools, if you see the global mortality here is 55%, but simple things like combining a comorbidity score like Charleston score in the x-axis and in the y-axis SOFA score, it can risk classify your patients to make bedside decisions. So you have a patient really with a very high comorbidity level and very high SOFA. You need to be very careful. Mortality rate is very high, as you can see in the top right, 83.6%, or if you really want to offer patient advanced extracorporeal support. This is, on a nutshell, the visual abstract of the study. You guys can review it. It has a lot of supplementary material. But importantly, on the top, I want to highlight that the most common contributing factors to AKI were sepsis, cardiogenic shock, and also major surgeries. Those were the 3 most common causes of AKI. On the right side, the most common indications for CRRT in these patients were the management of fluids, oliguria, anuria, and fluid overload. Globally were the most common indications. And then uremia was also one of the top indications for CRRT initiation. Now, this is the most exciting thing. I think that the registry will not only provide data that all of us as a community can use and can learn from it, but it's also going to help us to how to create the next generation of this type of registries. And there was a lot of data management transformation procedures to validate this data. And this will help the pipeline of future automated registries. So what we need to do in the future is to create these registries without manual collection by coordinators, automated with data feeds from the EHR and also from our devices. So this is a work in progress, and I think we will be one step forward every day that goes. With that, my take-home points are that from this study, the overall hospital mortality rate, to have in mind reference in North America, 58.9%. The most common reason for ICU admission was respiratory failure followed by sepsis. Sepsis was the major contributor to AKI, and fluid management was collectively the most common indication for CRRT. CVHDF was the most common modality, and regional citrate, the most common anticoagulation used in these centers represented in the survey. Again, as highlighted before, significant heterogeneity in patient and patient-specific and CRRT-specific characteristics was found in current practice. This data highlights the need for establishing benchmarks of CRRT delivery, performance, and patient outcomes. And of course, data from this registry could assist the design of future studies. Thank you for your attention.